Hello friends. Today we are going to discuss about the pulmonary embolism. So we'll see what are the predisposing factors for the pulmonary embolism. These are the fracture of lower limb, hospitalization for heart failure, atrial fibrillation, atrial flutter within the previous 3 months, hip and knee replacement, major trauma, myocardial infarction, previous venous thromboembolism, and spinal cord injury. Moderate risk factors include orthoscopic knee surgery, autoimmune disease, blood transfusion, central venous line, intravenous catheters and lead, chemotherapy, congestive heart failure and respiratory failure, erythropoiesis stimulating agent, and hormonal replacement therapy. In vitro fertilization, oral contraceptive therapy, then postpartum in a period infection, then any inflammatory bowel disease, cancer, paralytic stroke, superficial vein thrombosis, and thrombophilia. Then weak risk factors include if someone is on the bed rest for more than 3 days, diabetes mellitus, arterial hypertension, immobility due to sitting, that is prolonged car or air travel, increased age, laparoscopy surgery such as cholecystectomy, obesity, pregnancy, and varicose. Then what is the pathophysiology? Pulmonary artery pressure increases if more than 30 to 50% of total cross-sectional area of pulmonary arterial bed is occluded by thromboembolism. Then pulmonary embolism-induced vasoconstriction is mediated by the release of thromboxane A2 and serotonin, which contribute to the initial increase in pulmonary vascular resistance after P. So this anatomical obstruction as well as hypoxic vasoconstriction in the affected lung area lead to the increase in pulmonary vascular resistance and proportional decrease in the arterial complex. So the abrupt increase in pulmonary vascular resistance will cause RV dilatation, which alters the contractile properties of RV myocardium via Frank-Starling mechanism. The increase in RV pressure and volume leads to the increase in wall tension and myocardial stretch. So the contraction time of the RV is prolonged, while the neurohormonal activation leads to the inotropic and chronotropic stimulation. Together with the systemic vasoconstriction, these compensatory mechanisms will increase the pulmonary artery pressure, improving flow through the obstructed pulmonary vascular bed, thus temporarily stabilizing systemic blood pressure. However, the extent of immediate adaptation is limited as non-preconditioned thin wall RV is unable to generate mean pulmonary artery pressure of more than 40 mmHg. So the prolongation of RV contraction time in the early diastole in the left ventricle leads to the leftward bowing of the interventricular septum. The desynchronization of the ventricle may be exacerbated by development of right bundle branch block. As a result, LV filling is impeded in the early diastole, and this may lead to reduction in cardiac output, which contribute to the systemic hypotension and hemodynamic instability. Finally, the association between elevated circulating level of biomarkers of myocardial injury and adverse early outcome indicates that RV ischemia is of pathophysiological significance in the acute phase of P. Systemic hypotension in the critical element in this process leads to the impairment of coronary driving pressure to the overloaded RV. So respiratory failure. Next is the next manifestation of the pulmonary embolism is respiratory failure, which occurs because of the ventilation perfusion mismatch, right to left shunting, alveolar hemorrhage, and pleural effusion. So let's talk about clinical presentation. The clinical signs and symptoms of acute PE are non-specific, and in most cases, PE is suspected in patient with dyspnea, chest pain, pre-syncope, syncope, or hemoptysis. Then hemodynamic instability is rare but important form of clinical presentation as it indicates central and extensive pulmonary embolism with severely reduced hemodynamic reserve. Syncope may occur and is associated with higher prevalence of hemodynamic instability and RV dysfunction. Conversely, and according to the result of recent study, Acute PE, acute PE may be frequent finding in patient presenting with the syncope even in the presence of alternate explanation. Dyspnea may be acute and severe in central PE. In small peripheral PE, it is often mild and may be transient. In patient with the pre-existing heart failure or pulmonary disease, worsening dyspnea may be the only symptom indicative of the PE. Chest pain is the frequent symptom of the PE and is usually caused by pleural irritation due to distal emboli causing pulmonary infarction. In central PE, chest pain may have a typical angina character, possibly reflecting RV ischemia and requiring differential diagnosis from acute coronary syndrome or aortic dissection. So hypoxemia is frequent, but less than 40% of patients have normal arterial oxygen saturation and 20% have normal alveolar arterial oxygen gradient. Hypocapnia is also present. A chest X-ray is frequently abnormal, although its findings are usually non-specific in pulmonary embolism. It may be useful for excluding other causes of dyspnea or chest. Now, the ECG changes indicative of RV strain include inversion of T wave in the leads from V1 to V4, a QR pattern in V1, S1Q3T3 pattern, incomplete or complete RBP, which are usually found in more severe cases of pulmonary embolism. In milder cases, only abnormality which can be observed is sinus tachycardia. Finally, atrial arrhythmia, most commonly atrial fibrillation, may be associated with the acute PE. Then for a prediction of pulmonary embolism, there are two scores which can be used, is revised Geneva score and Wells score. So let's see what is this revised Geneva score. So revised Geneva score includes component like previous history of PE or DVT, heart rate of which ranging from 75 to 94 or more than 95, surgery or fracture within the past month, hemoptysis, active cancer, unilateral lower limb pain, pain on lower limb or deep vein palpation and unilateral edema, and age more than 6 years, 665 years. So, according to the clinical probability, this is divided into the three types, that is low, intermediate, and high. So, if the score is between 0 to 3, that means the probability of the P is very low. If the score is between the 4 to 10, that means the probability of the P is intermediate. If the score is more than or equal to 11, then the probability is very high. Then the another score which can be used for the prediction is the Wells score. And the component of the Wells score are clinical signs and symptom of DVT. So 3 points are given to that. Then previous history of DVT or PE, 1.5 are given to that. Then immobilization for more than 3 days or surgery within the 4 weeks, 1.5 points. Then heart rate more than 100, 1.5 points. Then hemoptysis 1, malignancy 1, and no alternative diagnosis, most likely P, that is 1. So after examining the patient, after taking history, if we are strongly, if history-wise and examination-wise, if we are suspecting P, then we can apply this Geneva score as well as this Wales score to find out how much, how the means. So the likely diagnosis is P or something else. Then the next score is PERC score. So PERC score is invented to rule out P. That means if there are total 8 criterias, if nothing is present, then we can rule out P clinically and there is no need of further investigation. So these include age less than 50 years, pulse less than 100 beats, saturation more than 95, no hemoptysis, no estrogen use, no prior venous thromboembolism, no surgery or trauma requiring hospitalization within past 4 weeks, and no unilateral leg swing. If none of the 8 criteria are present, then PE can be safely ruled out. Then next investigation, which can be performed on the bedside, is echocardiogram. And we'll discuss what are the signs that we can see in the echocardiography. So first sign is enlarged right ventricle in the parasternal long axis view. Second sign is dilated RV with the basal RV to LV ratio of more than 1. And then McConnell sign. McConnell sign is the hypokinesia of the apical region of the RV. Then the third sign is the flattened intraventricular septum, that is the D-shaped ventricle. Fourth sign is distended IVC. Then fifth sign is 60-60 sign, that is the coexistence of acceleration time of pulmonary ejection less than 60 and mid-systolic notch with the mildly elevated peak systolic gradient at tricuspid valve is less than 60. Then right heart mobile thrombus. Then decrease TAPSE, that is less than 1.6. And decrease peak systolic velocity of tricuspid annulus, that is less than 1, that is less than 9.5. So the 2D echo shows the following sign, that is 60-60 sign, McConnell sign, and the right heart thrombus. So if we found this sign, then just on the basis of this sign, we can take the decision of thrombolysis if immediately CT angiograph is not possible or our patient is highly unstable and it is not feasible to shift the patient to the CT. And if you see this mobile right heart thrombi, that means that means it has the high. Then there are the chances of mortality are very high, especially in patient with the RV dysfunction. So echocardiography may detect the increased RV thickness or tricuspid insufficiency jet velocity beyond values compatible with the acute RV pressure overload. In case of chronic thromboembolism and pulmonary hypertension should be included in the differential diagnosis. So in case of chronic thromboembolism, we can observe these signs like increased RV wall thickness or tricuspid insufficiency jet velocity. So next investigation that we can plan is the CTPA, planar VQ scan, VQ SPECT, and the pulmonary angiography. So CTPA is readily available round the clock in most center. It has excellent accuracy. It has a strong validation in prospective management outcome studies, low rate of inclusive result. It may provide the alternative diagnosis other if P is excluded. And the weakness and the limitation of the CTPA is radiation exposure to the iodine contrast, which limited use of iodine allergy and hyperthyroidism. It is a risky in pregnant and breastfeeding female, and it is a contraindicated in severe renal failure. And because it is easily available and accessible, there is always tendency to overuse it. Then the next in line of investigation that we can plan is the VQ scan. There are no contraindication, but it is relatively inexpensive. And strong value, there are no contraindication as well as it is relatively inexpensive than CT. And there are strong validation in the prospective management outcome studies. But the limitations are it is not readily available in all centers. Inter-observer variability in the interpretation. Results are reported as likelihood ratio. It is inconclusive in the 50% of cases, and we cannot, and this cannot provide the alternative diagnosis if PE is excluded. Then the next scan is the VQ spec. It has no contraindication, lowest rate of non-diagnostic test, high accuracy according to the available data, and binary interpreting. Then the limitations are variability of techniques, variability of diagnostic criteria. It cannot provide alternative diagnosis, no validation in the prospective management outcome study. Pulmonary angiography is the gold standard, but it is an invasive. And definitely we can means there are if non-invasive options like CTPA is available, then we'll prefer CTPA over pulmonary angiography. So the next study that we can perform on the bedside is compression ultrasound. In majority of the cases, the PE originate from the DVT in the lower limb, only rarely from the upper limb DVT. So compression ultrasound has the sensitivity of more than 90% and specificity of 95% for proximal symptomatic dip. So if our proximal compression ultrasonography is positive, then it has a high positive predictive value for P. So it is a useful procedure in the diagnostic strategy of the patient if CT is contraindicated. So if the patient has positive proximal compression ultrasonography, and if in suspected P, uh, then we can suspect the pulmonary embolism in that patient with signs and symptoms which are related to the leg vein than in symptomatic patient. So what I want to say is, if there is any patient with the uh, who uh, who shows the signs of PE, and if we perform the bedside compression ultrasound, and if we find that is a proximal DVT, then we can treat that patient as pulmonary embolism. So we'll see what are the recommendations. So in suspected high-risk PE, as indicated by the presence of hemodynamic instability, bedside echocardiography or emergency CTPA is recommended for the diagnosis. It is recommended that anticoagulation with unfractionated weight heparin, including weight-adjusted bolus, be initiated without delay in patient with suspected high-risk PE. The use of validated criteria for diagnosing PE is recommended. The initiation of anticoagulation is recommended without delay in patient with high or intermediate clinical probability of PE while diagnostic workup is in process. It is recommended that the diagnostic strategy is based on clinical probability, which are assessed by the clinical judgment or by the validated prediction rule. So next line of investigation is the D-dimer, and we'll see what are the recommendations for the D-dimer. So plasma D-dimer measurement, preferably using the high sensitivity assay, is recommended in the outpatient or emergency department patient with lower intermediate clinical probability or those that are PE unlikely to reduce the need of unnecessarily imaging and irradiation. As an alternative to fixed D-dimer cutoff, negative D-dimer test using age-adjusted cutoff should be considered for excluding PE in patients with lower intermediate clinical probability or those that are PE unlikely. So this range is age into 10 for patients who are more than 50 years of age. As an alternative to fixed or age-adjusted D-dimer cutoff, D-dimer levels adapted to clinical probability should be considered to exclude P. So D-dimer measurement is not recommended in patients with high clinical probability as normal result does not safely exclude P even when the highly sensitive assay. So those patients in whom we are who are at the high risk of pulmonary embolism, D-dimer doesn't carry any importance. But those who are falling in the category of intermediate and low clinical probability, we can send D-dimer. In that case, if D-dimer is positive, we can go for the further investigation to rule out P. But if it is negative, then it is safe. We can safely exclude it. Then we'll see what are the recommendation of the CTP. It is recommended to reject the diagnosis of pulmonary embolism if CTP is normal in patient with lower intermediate clinical probability or who is PE unlikely. It is recommended to accept the diagnosis of pulmonary embolism if CTPA shows segmental or more proximal feeding defects in patient with the intermediate and high clinical probability. It should be considered to reject the diagnosis of PE if CTP is normal in patient with highly clinical probability or who is PE likely. Further imaging tests to confirm PE may be considered in cases of isolated subsegmental filling defect. CT venography is not recommended as an adjunct to the CT. Then VQ scintigraphy. It is recommended to reject the diagnosis of PE if perfusion lung scan is normal. It should be considered to accept the diagnosis of PE if the VQ scan yield high probability of the PE. A non-diagnostic VQ scan should be considered as an exclusion of PE when combined with the negative proximal compression ultrasonography in patients with the low clinical probability or who are PE unlikely. VQ spec may be considered for PE diagnosis. Then lower limb compression ultrasonography. It is recommended to accept the diagnosis of venous thromboembolism if compression ultrasonography shows proximal DVT in patient with a clinical suspicion of the PE. If compression ultrasonography shows only distal DVT, further testing should be considered to confirm pulmonary embolism. If positive proximal compression ultrasonography is used to confirm PE, then assessment of PE severity should be considered to permit risk-adjusted management. MRA is not recommended for ruling out pulmonary embolism. Then the next score, then once the diagnosis of PE is confirmed, then we need to know how much severe is this PE. So for that we can use the PACE score. So once we know this PE is very severe, then we can predict the chances of the mortality. So we'll see what is this PACE score. PACE score includes the age. If it is more than 81 point, if male sex, 10 points. Presence of cancer, 30 points. Chronic heart failure, 10 points. Chronic pulmonary disease, 10 points. Pulse rate more than 110, 20 points. Systolic blood pressure less than 100, 30 points. Respiratory rate more than 30, 20 points. Temperature more less than 36, 20 point. Altered mental status, 60 point. Arterial oxyhemoglobin saturation less than 90, 20. So class 1 patient less than or equal to 65 falls into the very low 30-day mortality. If the PACE score is between 66 to 85, low risk of mortality. If it is between 86 to 105, moderate risk of mortality. Then if it is 106 to 125, then it has a high mortality risk, or if it is more than 125, very high mortality risk. Then the classification of the pulmonary embolism severity and risk of early death. So if risk of mortality is very high, if the patient is in the hemodynamic stability, if the patient is hemodynamically unstable, PACE score is high, RV dysfunction is present, and the cardiac troponin values are high. Then the early mortality risk is if it is intermediate, it is divided into high and the low risk. Intermediate high risk includes includes the patient who are hemodynamically stable but high CPC score, RV dysfunction, and elevated cardiac troponin. An intermediate low risk include hemodynamically stable patient with high PC score, or either there will be the RV dysfunction on the echo, or there will be the presence of elevated troponin. Low risk patient, patient will be diagnosed with the PE, but patient will be hemodynamically stable. Patient will be falling into the category of low PC score. There won't be any RV dysfunction on the echo, and cardiac troponin will be normal. So treatment, after diagnosing, after predicting mortality risk, now our next job is the treatment. So how to treat if the PE is in acute phase? So first is oxygen therapy and ventilation. So high flow oxygenation and mechanical ventilation in case of extreme instability, taking into consideration that correction of hypoxia will not be possible without simultaneous PE reperfusion. So the treatment of hypoxia in PE is the only one that we need to reperfuse that embolism. Then only the oxygen level will be correct. Then considering the pharmacological therapy for right heart failure. So acute RV failure with resulting low systemic output is the leading cause of death in patients with high risk PE. So if central pressure is low, then we can give the modest fluid challenge. But we should make sure we should not load the patient with the excessive fluid, because this excessive fluid will over distend the right ventricle, and it will cause the shifting of the interventricular septum towards the left side, and that will result into the low cardiac output. Assess the central venous pressure by examining IVC. If signs of raised CVP is seen, then stop the fluid resuscitation. The use of vasopressor is often necessary in parallel with the pharmacological, surgical, and interventional reperfusion treatment. Norepinephrine can improve the systemic hemodynamics by bringing about the improvement in ventricular systolic interaction and coronary perfusion without causing change in the PV. Its use should be limited to patients in the cardiogenic shock. The use of dobutamine can be considered in the pulmonary embolism. Levosimendan may restore the RV pulmonary arterial coupling in acute PE by combining pulmonary vasodilatation with increased RV contractility. Temporary use of mechanical cardiopulmonary support, mostly with veno-arterial extra ECMO, may be helpful in patients with high-risk PE, circulatory collapse, or cardiac arrest. Acute PE is the part of differential diagnosis of cardiac arrest with a non-shockable rhythm against the background of pulseless electrical activity. Thrombolytic therapy should be considered once the thrombolytic agent is administered, and cardiopulmonary resuscitation should be continued for at least 60 to 90 minutes before terminating reperfusion attempts. Now, this is the summary of the right heart failure in high-risk pulmonary embolism. So first is volume optimization, administered volume loading with saline or linger lactate. Make sure we should not give the excessive fluid. Then we can start the vasopressor inotropes in the form of norepinephrine and dobutamine. And if the patient is hemodynamically not improved, then we can, the last option is the ECMO. Then we can then for anticoagulation, we can use the unfractionated weight heparin, low molecular weight heparin, or the fondaparinux. In patients with the high or intermediate clinical probability of the PE, anticoagulation should be initiated while awaiting the result of diagnostic test. This is done with the subcutaneous weight adjusted low molecular weight heparin, fondaparinux, or unfractionated weight heparin. An equally rapid anticoagulant effect can be achieved with vitamin K antagonist oral anticoagulant. Low molecular weight heparin and fondaparinux is preferred over unfractionated weight heparin for initial anticoagulation in pulmonary embolism, as they carry lower risk of inducing major bleeding and heparin-induced thrombosis. So, neither low molecular weight heparin or fondaparinux need routine monitoring of the anti-10A level, and the use of unfractionated weight heparin is largely restricted to hemodynamically unstable patients or imminent hemodynamic decompensation in whom primary reperfusion treatment will be necessary. So, unfractionated weight heparin is recommended for patients with the serious renal impairment or severe obesity. And if low molecular weight is prescribed in patients with the creatinine clearance of 15 to 30, an adapted dosing scheme should be used. A dosing of unfractionated weight heparin should be based on activated partial thromboplastin time. Then the next line of action is the NOVACs. NOVACs are the small molecule that directly inhibited the one activated coagulation factor, which is thrombin for dabigatran, and factor 10A for apixaban, endoxaban, and rivaroxaban. So NOVAC can be given at fixed doses without routine lab monitoring. In phase 3 venous thromboembolism trial, the dosage of dabigatran, rivaroxaban, and apixaban was not reduced in patients with mild to moderate renal dysfunction, where endoxaban is given in the dose of 30 mg. The next drug is vitamin K antagonist. Vitamin K antagonist has been the gold standard in oral anticoagulation for more than 50 years. So when vitamin K antagonists are used, anticoagulation with unfractionated weight heparin, low molecular weight heparin, and fondaparinux should be continued in parallel with the oral anticoagulation for more than 5 days until INR value has become 2 to 3 for 2 consecutive days. So warfarin may be started at dose of 10 mg in younger adult and in otherwise healthy at the dose of otherwise healthy and in young patient at the dose of less than or equal to 5 mg. So daily dose monitoring is required in the form of iron. Then regarding reperfusion therapy, thrombolytic therapy leads to faster improvement in pulmonary obstruction, pulmonary arterial pressure, and pulmonary vascular resistance in patients with a pulmonary embolism compared with unfractionated weight heparin alone. So these improvements are accompanied by reduction in RV dilatation. The greatest benefit is observed when the treatment is initiated within 48 hours of symptom, but thrombolysis can still be useful in patients who had symptoms for 6 to 14 weeks. So thrombolytic regimen doses and contraindication. So there are three thrombolytic agents that can be used is RTPA, streptokinase, urokinase. So recombinant tissue plasminogen activator can be used in the dose of 100 mg over 2 hours. Streptokinase can be that is 0.6 mg per kg over 15 minutes. Uh, Maximum 50 mg in case of arrest. Okay. Then streptokinase can be given in the dose of this 2,50,000 as a loading dose over 30 minutes, followed by 1 lakh international unit per hour over 12 to 24 hours. Accelerated regimen is 1.5 million over 2 hours. Then urokinase can be given in the dose of 4,400 international unit per kg as a loading dose over 10 minutes, followed by 4,400 international unit per kg over 12 to 24 hours. Accelerated regimen is 3 million international unit over 2 hours. So in practice, we are using altiplase. So just remember the dose of altiplase. I'm repeating again, altiplase we can use in the dose of 100 mg over 2 hours. And if the patient is in cardiac arrest, that is 0.6 mg per kg, or we can administer 50 mg over 50 minutes. Okay. So we'll see what are the contraindications for the fibrinolysis. So absolute contraindications are history of hemorrhagic stroke or stroke of unknown origin. Ischemic stroke in previous 6 months, central venous system neoplasm, major trauma, surgery, head injury in previous 3 weeks, bleeding diathesis and active bleeding. Then relative contraindications are transient ischemic attack in previous 6 months, oral anticoagulation, pregnancy or postpartum weak, non-compressible puncture site, traumatic resuscitation, refractory hypertension, advanced liver disease, infective endocarditis, and active peptic ulcer. Now the next options are percutaneous catheter directed treatment. Mechanical reperfusion is based on the insertion of catheter into pulmonary artery via femoral. So different type of catheters are used for mechanical fragmentation, thrombus aspiration, most commonly pharmacomechanical approach combining mechanical or ultrasound fragmentation of thrombus within situ reduce the dose of thrombolysis. Then the next is surgical embolectomy. Surgical embolectomy in acute PE is usually carried out with the cardiopulmonary bypass without aortic cross clamping and cardioplegic cardiac arrest, followed by incision of two main pulmonary artery with removal and suction of fresh. Recent reports have indicated favorable surgical result in high-risk PE with or without cardiac arrest and in selected cases of intermediate high-risk PE. Then the next treatment option is vena cava filter. The aim of vena cava interruption is to mechanically prevent venous clot from reaching the venous pulmonary circulation. Relative indications include venous thromboembolism, an absolute contraindication to anticoagulant treatment, recurrent PE despite adequate anticoagulation, and other potential indication for filter placement, including free-floating thrombi. So, in the prevention of recurrent pulmonary embolism by vena cava interruption study, that is PREPIC study, insertion of permanent vena cava filter was associated with significant reduction in the risk of recurrent P. There is a significant increase in the risk of DVT without significant difference in the risk of recurrent VT or death. So broad indication for placement of venous filter in patient with recent proximal DVT and absolute contraindication to anticoagulant. And complications associated with vena cava filter are common and can be serious. 5% of patients required major intervention such as surgical removal of filter, endovascular stent placement or embolization, endovascular retrieval of permanent filter or percutaneous nephrostomy or ureteral stent placement. Further reported complications include filter fracture or embolization and DVT, occasionally extending up to the vena cava. So this is the recommendation for acute phase of treatment of high-risk P. It is recommended that anticoagulation with unfractionated weight heparin, including weight-adjusted bolus injection, be initiated without delay in patient with high-risk P. Systemic thrombolytic therapy is recommended for high-risk P. Surgical pulmonary embolectomy is recommended for patient with high-risk P in whom thrombolysis is contraindicated or failed. Percutaneous catheter directed treatment should be considered for patient with high-risk P in whom thrombolysis is contraindicated. Then norepinephrine and dobutamine should be considered in patient with high-risk P. ECMO may be considered in combination with surgical embolectomy, catheter-directed treatment in patient with PE and refractory circulatory collapse and cardiac arrest. Now, regarding anticoagulation, initiation of anticoagulation is recommended without delay in patient with high or intermediate clinical probability of P. If anticoagulation is initiated parenterally, low molecular weight heparin or fondaparinux is recommended over unfractionated weight heparin. When oral anticoagulation is started in patient with P who is eligible for NOAC, NOAC is recommended in preference to vitamin K antagonist. NOACs are given in the form of apixaban, dabigatran, endoxaban, and rivaroxaban. When patients are treated with vitamin K antagonist, overlapping with parenteral anticoagulation is recommended until INR is 2.5. NOACs are not recommended in patients with severe renal impairment during pregnancy, lactation, and in patients with antiphospholipid syndrome. Reperfusion thrombolytic therapy is recommended for patients with hemodynamic deterioration. An alternative to rescue thrombolytic therapy, surgical embolectomy, or percutaneous catheter-directed treatment should be considered for patients with hemodynamic deterioration on anticoagulation treatment. Then routine use of primary systemic thrombolysis is not recommended in patients with intermediate or high-risk P. Setup of multidisciplinary team and program of management of high and intermediate risk P should be considered depending on resource and expertise available in each hospital. IVC filter should be considered in patient with acute P and absolute contraindication to anticoagulation. Then IVC filter should be considered in cases of P recurrence despite therapeutic anticoagulation. Routine use of IVC filter is not recommended. Carefully selected patient with low risk P should be considered for early discharge and continuation treatment at home if proper outpatient care and anticoagulation treatment can be provided. Then this is the schematic representation of the treatment of suspected pulmonary embolism patient with hemodynamic instability. So in that case, we should perform the bedside transesophageal echocardiography. And we should assess for right ventricular dysfunction. If there is no right ventricular dysfunction, then search for other cause. If right ventricular dysfunction is there, then go for CT pulmonary angiography. If CT pulmonary angiography is possible, then go for it or treat accordingly. If not, then start the treatment as high risk P. In case of suspected pulmonary embolism without hemodynamic instability, Assess the clinical probability of the P by the clinical judgment and the prediction. If the patient is in high clinical probability for P, go for CTPA directly. If the patient is falling into intermediate and low risk probability, then send D-dimer. If D-dimer is positive, then go for CTPA, otherwise no need. Then any patient who is diagnosed with P, start the anticoagulation. Then the further treatment is based on the hemodynamic instability. If hemodynamic instability is present, then the P is in high risk, start the reperfusion treatment. If hemodynamic instability is not there, then divide the patient into intermediate high risk and intermediate low risk. Now how we will do that? So we'll divide this patient based on our PACE score, based on our right ventricular echo finding and the biomarker. If PACE score is high and if on echo showed right ventricular dysfunction and cardiac biomarkers are positive for this patient, then patient is falling into the intermediate high risk category. Then continuous monitoring is needed and rescue reperfusion is needed if the patient's condition is deteriorating. But if the patient is falling into the intermediate low risk category, then we need to at least hospitalize the patient and monitor. And if patient is falling into the low risk category, if there is no reason for the hospitalization, patient has family social support and easy access to the medical care, then we can discharge the patient on the anticoagulation. Now these are the few trials which are published in the context of PE. So first one is PETHO trial. So this is about the patient with the intermediate high risk PE. So according to this trial, fibrinolytic therapy prevent the hemodynamic decompensation, but they increase the risk of major hemorrhage and stroke. So the next is Einstein trial. So what Petro trial wants to say that if the patient is falling into the intermediate high risk category, then try to manage this patient with the anticoagulant instead of thrombolysis. Then the next is Einstein trial. So according to this trial, fixed dose regimen of rivaroxaban alone was non-inferior to the standard therapy for initial and long-term treatment of pulmonary embolism and had potential improved beneficial risk profile. Then the next is axiomatic trial. So post-operative factor 11A inhibition with the oral milvexian in patient undergoing knee arthroplasty was effective for prevention of venous thromboembolism and associated with the low risk of the bleeding. Then the next is PEG-ED trial. Combination of the low CPTP and D-dimer level of less than 1000 per millimeter identified the group of the patient at low risk of PE during follow-up. So what I want to say is if the patient has low risk category, low clinical probability, and the D-dimer levels are also low, then the risk of the PE is very low. Then the recently published is FLAME study. According to FLAME study, in hemodynamically unstable high-risk PE, patients selected for flow trigger mechanical thrombectomy incurred low risk of an in-hospital adverse clinical outcome. Thank you, guys.